24 people and growing. And so I will slowly start wading into an introduction. Thank you, everybody, for joining us for the Health and Medical Geography Specialty Group speaker series, webinar series, what have you. I should have checked my notes to find out how many years in a row we've been doing this. I know in the past there were some ideas of, oh, we'll do it like multiple times a year. And I think, at least for us this year, we were encouraged and satisfied to land on at least once a year to help bridge us over until we all meet together again in March. And I was just chatting with Dr. Kolak, who's at UIUC, who's the vice chair of our specialty group, and I'm Dick Sadler. I'm at Michigan State University. I'm the current chair of our specialty group. I'm excited today to introduce two speakers who are geographically on opposite sides of the continent. And so I think we'll, in that geographic sense, we'll have a broad spread of disciplinary ideas to share. And I think what I will do is I'll introduce each speaker like one at a time, because I want to share a bit about them, both that they had shared and then a couple extra pieces that I had picked out either from their CVs or from their profiles. And both speakers were very, what's the right word? I'm missing the word. Very willing to defer to one another as to who went first or second. And so I kind of looked at their abstracts and made an executive decision, thinking that Dr. Planey's work is going to segue neatly into Dr. Eberhardt's. And of course, I could probably make the same argument vice versa. But what I'm going to do now is introduce Dr. Planey first. And then after Dr. Planey speaks for about 20 minutes, I'll introduce Dr. Eberhardt, who will then also speak for 20 minutes. And then we'll have a few minutes for Q&A and crosstalk and so forth. So we'll save questions like till the end, and then that way the questions can be motivated for both speakers. So just write them down and keep them in mind. So Dr. Ariana Murray Planey is an assistant professor in the Department of Health Policy and Management in the Gillings School of Public Health at University of North Carolina at Chapel Hill. She has expertise in measuring and conceptualizing healthcare access, including equity in access and outcomes, with attention to intersections of race, class, gender, and disability status. Her work has addressed reproductive healthcare access and outcomes, health system restructuring and its impacts on population access to care, and the intersection of cancer care-related travel and financial burdens. Dr. Planey completed her PhD in geography from University of Illinois at Urbana-Champaign, after earning her master's and bachelor's degrees from University of Chicago and UC Berkeley. Dr. Planey is also the 2023 UNC Gillings Faculty Award recipient for excellence in health equity research, and also won the Peter Gold Student Paper Award with the Health and Medical Geography Specialty Group a few years ago. She's also lead author on papers published in Social Science and Medicine, the Journal of Urban Health, and the Journal of Healthcare for the Poor and Underserved, among other places. Dr. Planey, I'll give it to you.
Thank you so much. I need to write a better bio, one that's easier to read. But thank you. First, thank you so much for having me. I have a timer going, so I'm not going to go over. I'm going to start my screens. All right. So I really had difficulty writing this presentation because 20 minutes feels like both like a long time and a very short time. So I'm going to go through a few case studies, but kind of start with the conceptual piece. So thinking about time with a social determinant of health, and I kind of propose that it's a missing link in studies of health and healthcare equity, or inequity. And I say that mostly as a geographer who's an academic public health. I think a lot of this is what geographers are more attuned to these issues than people who are maybe not trained in geography. So this is just to give you all an overview of what I do. I have a lot of projects. A lot of times I kind of function as sort of a methodologist. So, but the projects that we'll touch on today are the ones on financial toxicity and time scarcity among rural-dwelling cancer survivors, and rural hospital closures and downstream impact on cancer screening or care access and cancer screening receipts among rural dwelling adults. So why time? So time I think of time through several kind of lenses, but we can first start by thinking through structural racism and other structural forms of discrimination, group-based discrimination. Structural racism has been defined as a macro-level system, social forces, institutions, ideologies, and processes that interact with one another to generate and reinforce inequalities among racial and ethnic groups. And kind of bringing it back to geography, this paper was more about landscapes, but there was a quote that stuck with me the first time I read it, and I always come back to it. And it helped me kind of think about when we talk about space, we're always talking about time. And you can fold in race or racialization or racism by thinking about it through the lens of space and time as being racialized. So when you think about so there's the racialization of space and the spatialization of race. And the most well-known example of that is racial segregation. And so from this article, thinking about the lived experience of race as having a spatial component or spatial dimension, and the lived experience of race also has a racial dimension. And because when we're talking about space, we're always talking about time, you can think about racial time or racialized time. And there's a whole lot of really great work on racial time. But my work is a bit more on the applied side of the spectrum with a focus on what that means for health and healthcare outcomes. So because time is because time is differentially allocated by race, time may account for some of the racial inequities in health. Conversely, this also implies that racial and ethnic minorities potentially have the most to gain by interventions that promote time equity. And so in the research on health and healthcare outcomes, particularly with focus on policy, healthcare policy and health policy, there's more often a lot more focus on whether an implemented policy achieved its stated aims, but there's less focus on the time burdens of social policies and programs, and the cost that they impose on the people who most need those programs but can least afford the costs that are imposed on them. And so one example of that is Social Security insurance. So between 2008 and 2019, nearly 110,000 disabled people, or about 1.2% of applicants, died prior to receiving a final decision about their appeal for SSI. The way that process is designed is you are generally by default rejected the first time, but successful applicants are those who are able to hire legal representation. And so this is an example of what's been called administrative burden. So where like these barriers are kind of built into program implementation, and it basically weeds out the people who would be most expensive to serve. And so I turn back to geography. So thinking about like what kind of geography for what kind of public policy, to David Harvey. And in the health and healthcare policy making, we've seen definitely what's called a neoliberal turn, sort of an experimental turn in U.S. policy making that often imposes taxes on people who are most impoverished. And so there's a growing body of work on administrative burdens or onerous burdens placed on people or communities in greatest need. And that includes administrative burdens associated with access in healthcare. And we see that this increases the likelihood of foregone care, especially among Black and disabled patients. And these patients also have longer wait times for appointments. For SNAP and WIC, so food programs, nutrition support programs, the requirements for in-person appointments to continued eligibility for SNAP or WIC have actually reduced continuity and coverage. Medicaid work requirement, which in some states require a person to demonstrate that they have allocated 40 or more hours of active job searching in order to maintain eligibility for Medicaid. And this is despite the fact that most people who are eligible for Medicaid actually do work. Many do work full time, but they do not receive insurance coverage through their jobs. And amid the COVID pandemic, there were cuts to unemployment benefits ostensibly to induce re-entry into the workforce. Um, and so in terms of health insurance, we also see this. We see that the administrative burden or the time cost of dealing with insurance companies adds up to about $21.6 billion a year in lost productivity. So thinking about back to time as a social determinant of health. So we can think of time as a resource that is socially patterned, and that this patterning is fundamentally shaped by the distribution, the spatial allocation of key resources, and that includes jobs and healthcare, housing. And so in addition to longer wait time for needed care, Black and Latinx people in the U.S. experience longer travel distances to access needed care. And there's analogous research in the UK has found the same for Black and Asian people in the UK. Overall, people of color experience high degrees of time scarcity, attributable in part to the disproportionate occupational sorting into precarious jobs without paid sick leave, longer work commutes that are born of a spatial mismatch between where they live and where they work. And there's been some previous work that looks into sort of how those long commutes are they kind of force a trade-off between wages, commute times, and housing affordability. And also in the context of like higher chronic disease prevalence in Black and Latinx communities, we see that time scarcity is associated with greater difficulty in chronic disease management, and that includes diet modification. And so part of that backdrop is supermarket redlining, where in the second half of the 20th century, with white flight, we also saw grocers leaving the inner city and going and moving with like more affluent white people who left the city to the suburbs, leaving what some might call food deserts in like the neighborhood that remain majority Black. But you do generally see it that people in the majority Black neighborhood also have poor access to quality, nutritious food. Um, So in terms of implications for healthcare inequality, particularly for rural residents, travel distance to care is a key barrier to healthcare utilization that not only impacts the frequency of care, but also impacts timing and cost of hospital visits and potentially affects health outcomes, the healthcare outcomes. The longer travel time to access care has longer downstream implications for patients that include elevated risk of hospitalizations, so avoidable hospitalizations for what are called ambulatory care sensitive conditions. So conditions that could otherwise be managed if they had access to preventive care. So basically, like a lot of the services you could receive in an office visit. Longer ambulance travel time and worse survival rates for emergent conditions, so heart attacks, traumas, lower rates of post hospitalization follow-up care, and higher rates of emergency department use in the post-op period. Delayed cancer diagnoses and worse severity of conditions. So this is particularly for stageable cancers. So thinking about and conceptually, so what will you measure? So if you're thinking about time as a social determinant of health, what do you measure? So you can measure the spatially uneven and racially disparate distributions of harmful exposures, and also inequities in access to health enabling resources. So like green space, jobs, healthcare. You can also measure time use. So thinking about the time cost of commuting, accessing healthcare services, accessing childcare. You can also think about wages, because when you're talking about wages, you're always talking about time. And so, but you can also kind of make it a more sophisticated approach, could be also looking at trade-off with commute time and housing costs. So thinking about those trade-offs and layering. So this is where you have a real opportunity to look at those intersections of gender, disability, occupational sorting, education. So all of these factors that play into where people choose to live, where people choose to work, where are those trade-offs that people face. So I'm gonna go through. I have about 9 minutes, so I'm gonna go through maybe two case studies. I had four in this one, but I think I can go through two. So this first paper looked at rural hospital closures and access to care among rural dwelling adults, and this was a collaboration with geographers and health services researchers. So what we know is that about 70% of counties classified as whole or partial primary care health professional shortage areas are rural. These counties are also where the vast majority of rural hospital closures have occurred. So the implication is that rural hospital closures exacerbate pre-existing shortages of healthcare professionals, particularly including primary care providers. Um, and there's some I'm not going to get too much into that, the dynamics of that, but we're going to look at the access piece. So what we know is that so this is a map showing counties with rural hospital closures overlaid on tract level share of Black residents. So the contemporary wave of hospital closures has had racially disparate impacts. So between 1990 and 2020, about a 31-year period, rural hospital closures became increasingly concentrated in U.S. South. And so in the last decade, from 2010 to 2020, about 70% of hospital closures occurred in this region. And it's like why we should focus on this region. An interesting dynamic in that 30 years is that these hospital closures, they used to more frequently occur in the more remote rural places that had majority white residents. But in the past 20 years, what happened was you saw this shift where closures, these rural hospitals that closed were in rural communities that neighbor urban areas. So like rural communities that are sort of at the interface of rural and urban. And these are also communities that have much higher share of Black and Latinx residents. And so these are also all hospitals. And when you look at the financial performance of the hospitals in these communities, the the vast majority of them are at elevated risk of financial distress and closure. And so we focused on the U.S. South region, which is home to about 38% of the U.S. population and 52% of Black people in the country. And here, this is a map just showing the routes to the nearest hospital for each rural tract across the South. Travel distance rather. And this is the same for second nearest hospital. And so our study area included just over 3,500 census tracts nested within 790 rural counties in the South. And so this area covered about 12.6 million rural residents. So we estimated travel distances and travel times for network of travel distance and travel time. And our estimates were actually quite similar to the National Household Travel Survey. And so what we found was that for rural residents in the South, the mean travel distance to access the nearest hospital and the second nearest hospital were about 22.6 minutes and 35.5 minutes, respectively, so one way. An overall mean of 35.4 minutes travel time among NHTS respondents. So this is a map showing changes in travel distances and time to the next side. Yeah, this is the travel distance and travel time to the nearest and next nearest hospital changes. And so what we saw is that between 2007 and 2018, nearly half of rural tracts in the South, residents in those tracts experienced worsened spatial access to the nearest hospital. And from 2010 and 2018, so travel time to travel distance and travel times to the nearest hospital. So, but the nearest the increase was from about 9.9 miles to 15.9 miles. So pretty substantial increase. And to the second nearest hospital, that increase was from about a mean of 14 miles to about 22.6 miles in 2018. But probably the more important takeaway here is that the rural tract where residents experienced worsened spatial access were rural tract where people had worse outcomes, worse spatial access to begin with. So these increases in travel times to get to either the nearest or second nearest facility are already occurring in places where people had to travel further to begin with. And interestingly, those were in communities that would be otherwise classified as less rural, because they're more adjacent or neighbor a metro area, but they had to travel farther to get to a hospital. Move to the next section. So generally, This is just to highlight the point that when you're looking at overall averages, you're masking the spatial and ethnic disparities in travel burdens to access acute care. So travel distances to nearest and second nearest hospital generally increase with rurality. But what you see when you look at racial composition of a tract, you see that residents in majority Black and majority Latinx rural tracts had the longest travel times to their second nearest hospital compared with their nearest majority white tract. So this is a challenge because this challenges some of the most common approaches in rural health research, where they typically focus on access to only the nearest facility. And consistently, what you see in that research is that, oh, white rural residents have poor access. But when you pay attention to, okay, so what if people bypass the local facility? Do they have to travel farther? Do you see racial and ethnic disparity that you might miss if you only look at the nearest facility? And yes, you do. So what you see here is that as the tract level proportion of Black residents, here we go, make sure I have 2 minutes. As the tract level proportion of Black residents increases, so too does the additional travel time to access the next nearest open hospital. I'm going to move a little bit farther, and I'm going to just move this point here. The U.S. South actually has some of the highest rates of avoidable hospital bypass. So like the disparities that you see here are notable. And so in the follow-up work, I looked at some like cancer screening receipt, using the same data set, but basically enriched it. And so this was the conceptual framework that kind of anchored that, and we were so more focused on the health workforce dynamics and also the patient impact. So worsened access to preventive care and cancer screening, exacerbated racial and ethnic disparities and travel burdens. And generally, the result was reductions in cancer screening, so breast, colorectal, and cervical cancer screening among rural dwelling adults. So here, basically, I wanted to emphasize that we're thinking about travel burden as cumulative temporal and financial cost of travel associated with cancer care, cancer screening, cancer treatment receipt. Let me see. So overall, we did find reductions in cancer screening among those affected by hospital closures, especially among women. And I'm gonna keep it moving. So did go over this more conceptual piece on the intersection of financial toxicity, which is defined as the patient level impact of the cost of cancer care and travel burdens. I'm not going to go too much into it, but the conceptual framework we can see here. And we have reviewed the literature in cancer, like the cancer outcomes research. And what we found was that you can think of this several approaches I can explain, but we can think of travel burden for cancer care as a moderator of that relationship between financial toxicity and cancer patient outcome. And so there's a couple of examples I pulled out. Here. I pulled out where we're looking at patient decision-making, treatment decision-making. So patients with greater travel distances to care were less likely, so those with soft tissue sarcomas, were less likely to choose basically the gold standard or recommended treatment, radiotherapy, and more likely to choose surgical treatment, in part because it had lower associated burdens of travel. And similar, we see like for breast cancer patients with greater travel distances from radiotherapy facilities, they had lower likelihood of breast conserving mastectomy. And then also you have a relationship where you can think of a mediator, where in the case of early stage gallbladder cancer, the compounding indirect cost of radiation therapy was consistently higher. Was consistently higher than that for endoscopic incision. And so when you imported, so they did some kind of experimental approach, and they included that cost of those compounding costs of radiation therapy appointments. Patients were more likely to choose the surgical option. So I'll stop there. So thank you again for having me.
Yeah, thank you so much for those thoughts. I have a lot of notes that I'll save for later. But yeah, hopefully we'll get to lots of questions here in just a few minutes. So yeah, thank you to Dr. Planey for those remarks. Our second speaker in today's speaker series is Dr. Avery Everhart, who is an assistant professor of geography at the University of British Columbia and an affiliate member of the Institute for Gender, Race, Sexuality, and Social Justice. She works across informatics, geography, critical data studies, and transgender studies. Her current projects include quantifying geographic access to gender-affirming care, developing intersectional methods in biomedical informatics, and she's working on a book on trans data and misinformation. She's also a co-founder, director of finance, and distinguished fellow with the academic nonprofit think tank, the Center for Applied Transgender Studies. Dr. Everhart completed her PhD in geography at the University of Southern California after earning her master's and bachelor's degrees at Queen's University and UNC Greensboro. Dr. Everhart is also the recipient of the Outstanding Dissertation Award from the Digital Geography Specialty Group of the AAG and has been lead author on papers also in social science and medicine, as well as spatial and spatiotemporal epidemiology and transgender studies quarterly, among others. Dr. Everhart, I'll pass it to you.
Thanks so much. Always a bit of a trip to hear your academic history narrated back to you, but I appreciate it. I'm going to share the PowerPoint directly, and hopefully that will mean that you can see what you're supposed to see and not my lengthy notes. How does that look? Cool. Thank you so much. And thank you, Dr. Planey, as well. It's been a while since I've gotten to see you speak, so it's really cool also, even though I wish there was more time, to get to see some of your more recent stuff narrated a bit too, and I'm sure we'll have plenty to talk about. Yeah, so thank you again to Hanlon and Dick and Marinia and everybody else for organizing this, and to HMGSG for having me. I'm going to do some potentially frustrating, lofty thinking about how we theorize and define access, especially access to healthcare. And I'm a little more nervous than I usually would be because I'm actually talking to medical geographers who absolutely know what's going on. So bear with me and feel free to poke holes, ask critical questions. I'm happy to hear it. So to begin, this is coming from my chapter in an edited volume, I believe it's called Place and the Social Spatial Determinants of Health, that Drs. Marinia Kolak and Emil de Moise are editing. That'll be out at some point soon. And this is the first time I'm presenting on it. So again, I'm like, sort of foregrounding that this exists in a chapter, it's been written, but that the ideas are still in progress. So I really found myself after my dissertation kind of frustrated with the notion of access and how it's defined so differently in different fields, and how we might draw from multiple fields and have a more transdisciplinary, multidisciplinary conversation about access. And in so doing, I turned to medical geography, spatial epidemiology, for the way that we foreground both spatial analysis and also place-based thinking and the importance of geographic context. But turned also to intersectionality, and especially this more recent and really rich literature in public health on intersectionality and its adaptation through empirical methods, for the ways in which it sort of reframes health and access through an analysis of power and offers social and historical and legal context in a lot of ways. And then lastly, from some of my training in my PhD, I continue to think a lot about international human rights law, but also broadly health and human rights. And so there is kind of this legal precedent that in the US maybe does or doesn't exist to the same degree that it's taken seriously elsewhere. And having spent some time going back and forth to Canada and being back in Canada now, I'm like, it's quite different. But there are legal precedents and insights from the human right to health that I think are quite useful for thinking about access. So I'm drawing from these three, and the context of the chapter was also about the social and spatial determinants of health. So there's some of that as well, but I'm trying less to frame this as an intervention onto one of those sort of core 5 determinants of health as access to care and quality of care, and more as something holistic and more broad in terms of how we frame access. And at a certain point, I was tasked with creating a conceptual model, and I am so terrible at those. So all we have is a Venn diagram. But it serves as a little bit of a roadmap for what I think is at least most immediately salient toward a transdisciplinary theory of access from these different fields and schools of thought. So pulling, of course, spatially explicit methods, but also a spatial approach to social determinants of health from medical geography, thinking about social and historical context, and a really core theoretical foundation and approach from intersectionality. And then health and human rights offers a legal and political precedent that I think also can help to adapt our thinking beyond how much of the science seems to come from the US specific context, and that how it might be adapted in different national contexts and different health systems, as well as a much more expansive framework of accessibility. And that might seem a little like underhanded or shady. It's not meant to be. It's just that you'll see quite literally a very expansive way of thinking about access. So there have indeed, of course, been theoretical interventions in medical geography as well, writ large. And lately I've been revisiting a lot of May-Po Kwan's work, some of her foundational work on access, also thinking about space and time. And then, of course, the uncertain geographic context problem, which plagues and haunts me in really useful ways. And of course, we can even trace it all the way back to Tobler and the first law of geography for this sort of revolution in quantitative geographic thinking in human geography that it spurned on. And this is also one of my favorite things to teach students because it's so fascinating to think about this as our sort of foundational principle in quantitative geography compared to traditional statistics, et cetera. There's also been a lot of really great work, too much to cite even, that adapts theory both from GIS world and social science world, and still prioritizing Cartesian representations of space. At least that's my focus. There's a lot of non-Cartesian and sort of non-representational stuff that's really fascinating as well. My colleague Luke Bergman in my department here does some really, really fascinating stuff. But I tend to think about generalizability and applications. So I'm focusing a lot more on more traditional Cartesian representations. And of course, from medical geography, we've seen a lot of innovation in terms of our capacity to quantify aspects of area level measures, neighborhood levels, definitions of neighborhoods, and the role of a more micro or meso scale, especially in thinking about social determinants of health. And in terms of methods, access to healthcare is quite often, of course, not exclusively, but quite often defined by things like drive time isochrones or distance to the nearest facility for obvious reasons and for really important ones. But it also, when we look at certain methods, like I've done work using a 3-step floating catchment area, there's a consideration of supply and demand that also adds a layer of sophistication and nuance. And we get that because the FCA series comes from gravity-based models borrowed from economics, of course. But even these gold standard methods are developed for particular kinds of care that do a little bit take for granted the fact that it requires lots of data and information. And that, and this is something that Dr. Planey's work also speaks to, how difficult it can be to disaggregate and therefore to even identify disparities, even if we know anecdotally, we know experientially, we know from other work that disparities do exist, that they are happening and that they're having effects on people's lives. But this also can enable us to foreground the scale of population, which is quite different from thinking in some of the work I've been doing with biomedical informaticists, that there's a really interesting way that even in using like natural language processing, machine learning, deep neural networks, this type of stuff, that still it tends to come back to the level of the individual and how can we think about biological mechanisms. And I'm still very much a population person. That's kind of how I think about it. And the extent of what that looks like, even when we want to do work on a smaller or a more marginalized population, this comes from the paper that I had on the last slide. that we can pull from other data sources. So to give context here, it's a little bivariate map. We love bivariate maps that shows cold and hotspot access to gender affirming hormone therapy within Texas for trans people, compared to whether or not those census tracts fall in areas that are considered medically underserved by HRSA in the States. So not a really formalized way of saying like care deserts per se, but rather as a point of comparison to sharpen a contradiction between patterns of spatial access to gender affirming care versus primary care for the general population. The paper is open access. It's in spatial and spatiotemporal epidemiology. I believe as of a couple of weeks ago, it's still the only one that will come up if you search transgender on SSTE's website. So it's easy to find. But just to show that like it can still do quite a lot, and it can tell us really interesting things. And adapting it for my work on trans populations, it also showed me something really important, that we can't assume that smaller populations, marginalized populations, and communities are necessarily experiencing the same spatial patterns around access to care that the general population is. Which then leads me to thinking about intersectionality and its empirical discontents, I guess we could say. There's obviously not enough time to do a full tilt intellectual history of intersectionality, but it is of course attributed to Kimberly Crenshaw in Mapping the Margins and other work, and arguably also Patricia Hill Collins, though she's not using the exact same word at the time, and she's since done quite a lot to take up intersectionality and adapt it in other contexts. There's a different intellectual genealogy that could trace it back to the Combahee River Collective Statement and even arguably Sojourner Truth. So there's a lot there that's really rich and steeped in this Black feminist intellectual history. But more recently, Lisa Bowleg in particular is considered by many to have done some of that groundwork of bringing intersectionality into public health. And a really foundational paper from 2008 that I highly recommend to everybody. And then some later work that also draws on qualitative methods. And later we can see some channeling of intersectionality into quantitative methods, especially from folks like Greta Bauer, but also my colleague Aidan Scheim, who done work to identify shortcomings of its application. So there's kind of an argument that intersectionality and quantitative methods might be at odds. But that sort of assumes that there's only one way that quantitative methods could ever be used. And then of course, a colleague, Elle Lett, has done quite a lot in this area as well across domains to bridge thinking around policy analysis, trans health, intersectionality, and really thinking about structures and systems in a really, really, really important way. And there's a whole growing oeuvre that I think is worth reading. And then specifically thinking about the adaptation of intersectionality to quantitative and computational methods, I think the key point for me here is that, of course, these would seem at odds if we assume that quantitative and computational is necessarily positivist, that it can get at a truth of something, and that is the truth, and that is the only way to express it, and that it's only about the math and the numbers and are the statistics correct, et cetera, rather than about empiricism in a way of saying, how can we observe the world and in what ways do data and these methods allow us to observe it from different angles that we wouldn't be able to see proprioceptively, for example. But in thinking about how the quantitative intersectional stuff has happened, Bauer and Scheim, who I just mentioned, identified that a lot of work takes one of three approaches: an inter, an intra, or an anti-categorical approach, wherein often I hear this sort of refrain that like, well, intersectional quantitative stuff means you have to have like a lot of data. And that's because it's coming from this assumption that you need to have ever more specific subgroups that you can do intercategorical comparisons with, and then that's what it means to do intersectional quantitative work. But there's been an impetus in more recent years to think, well, actually, what if it's not necessarily just about the analytical methods and developing new ways of doing that, but also about the theory behind it, how we actually adapt intersectional thinking to existing methods. So some approaches take demographic measurements as proxies for exposure to systemic oppression, and that's seemingly almost like a light bulb moment of like a simple reframe, but something that can be quite powerful. And something that we talk about in this JBI paper on opportunities for incorporating intersectionality into biomedical informatics. And a really fantastic paper from I believe it's Claire Bombra in 2022, points out that quantitative intersectional research, while it's making leaps and bounds in a lot of ways, still is yet to take space and place seriously and poses questions about what that might look like. And I would add scale to that, that there's a way that we can also be thinking not just macro and micro, but also mezzo. Which then leads me, if you're following, and if you're not, then thank you for entertaining me, leads me to thinking about this triple AQ framework that comes from the International Covenant on Economic, Social, and Cultural Rights. This is from 1966. It's international human rights law. In particular, it's been developed a few times over, and there's a general comment, number 14, on Article 12 of ICESAR, that's the right to the highest attainable standard of health that comes from 2000. Again, it's continued to be expanded upon, written upon. But the framework stands for availability, accessibility, acceptability, and quality, and it has become a normative framework. And by norm, I mean it establishes a legal precedent, a norm in that way, as opposed to like a social norm. And it also relates to and recognizes social determinants of health as SDOH has become a bit more de rigueur. And the map here just shows which state parties are actually party to ICESAR. And the reason I shared is because the US is not. The US has not actually signed or ratified it. There are other international covenants that the US has signed, but I point this out to just sharpen the contradiction between how much of the scientific research and public health world, even stuff that takes up human rights, comes from the US, but in a context in which we're not actually party to the covenant that really outlines the highest attainable standard of health as a right. So thinking more in depth about what the AAAQ framework is, availability is about, are there facilities, goods, and services, insufficient quantity, and are they physically available? Whereas access in the AAAQ framework is, are they accessible to everyone within the jurisdiction of the state party, which creates a norm around a duty. The state party has to provide this. And it has 4 overlapping dimensions of non-discrimination, physical accessibility, economical accessibility or affordability, and information access as well. And then acceptability, we could absolutely trouble the language as well, but it's that these must be respectful of medical ethics and culturally appropriate and sensitive to gender and life cycle requirements within the facilities, goods, and services being provided. And then quality is probably the most straightforward in the sense that it's got to be scientifically and medically appropriate and of good quality. In my view, a lot of our work in medical geography, spatial epidemiology tends to define access just as availability. Are healthcare facilities physically available? Where are they? And part of that is for a damn good reason, which is that a lot of work in the States points out that there's not enough care available. There's a health workforce shortage. We're also feeling that here in British Columbia and Canada. It's really difficult to get a family doctor here, and without a family doctor, you're relying on walk-ins, you can't get referrals. And that's with a single payer system. That's with provinces actually being responsible for their own health systems and delivery of care. But a lot of our work really does tend to focus on availability, and we may take up these other things as well, but it's not that the thinking stops here, it's that it's so difficult to even get to a level of scientific rigor that we can derive really meaningful insights about where care is available, that adapting these other things can be that much more difficult, requires that much more data that might not be available, requires that much more work. So in thinking about an adaptation of this framework for quantitative spatial methods, there are indicators for those 4 pillars of access on non-discrimination, information access, et cetera, but they do tend to be qualitative or subjective. So that's a human rights model. They'll have a special rapporteur for health. They do country visits. They write up a report. Still really useful, but not exactly what we're up to all the time in medical geography. But these other pillars, in my view, could be quantified. They could at least be treated in a way that could be incorporated into our spatial analyses. And that we could do that through existing methods that might be considered gold standard. And again, I know like there's far more than the floating catchment area series. I just love them because I love network analysis, but that's just me. There's a lot of really great stuff, including by Dr. Kolak, that's done some adaptation of other kinds of things that can incorporate like real-time availability, et cetera. But I also think that these could be adapted based on scale and the geographic context of health systems, and even in intersectional ways. So in thinking about what some of those variables of interest might look like, at least in some health systems, this could be availability of interpretation for services, translated materials. And here I'm thinking of our colleague Aida Golan-Cozy's work on access for Hispanohablante women in Chicagoland. We could also think about fee model and consent model. And consent model, I think, is especially important in areas that I work in on trans health, but also more broadly in sexual and reproductive health. In anything really that might be stigmatized or politicized in particular ways, arguably all healthcare, but still. The number of providers, which is something we have in floating catchment area already. Private insurance, Medicare, Medicaid in the context of the US, but single payer versus extended health in Canada, there's other systems as well. And trained and knowledgeable staff. That might look like cultural competency, that might look like a lot of things. But in some of my current primary data work, we have survey questions that we've asked about this that are about patient reported ratings, essentially, of the quality of care, the respectfulness of staff, and the knowledge. And one of the things that we found qualitatively is that, especially for trans patients who do travel further than they might need to, so there are more nearby facilities, that's not the one that they access, they often say that the most important thing is that not only are doctors and clinicians respectful, but they also are willing to say when they don't know, and they're also willing to do the research when they don't know. And I thought that was really, really lovely, and also a little sad, of course. But putting the pieces together as best I can, and this is still relatively a short chapter, all things considered, but trying to present it to you all. We can consider how we account for or even quantify how the legal and the health systems interact while still safeguarding the rigor of quantitative and computational methods. And I don't just mean the rigor in the sense of these are better than qualitative, but also that there is sometimes an idea that, like, well, the best available method requires this kind of thinking, requires this kind of data, requires these steps of analysis. And I think that we can fold in our thinking to those methods rather than having to make the methods either less complex or anything like that. I think we also can take Lisa Boleg's recent call for intersectional praxis in public health quite seriously. She's talking about health equity. She wrote it in the context of the early days of the COVID-19 pandemic. It's a piece in AJPH. I don't think I have all of my citations on a slide, but I'm happy to provide those if people want. But the takeaway is that rather than just documenting disparities, which is still important, especially if there are communities about which we don't have enough data, like trans communities, like Pacific Islander, Native Hawaiian communities that are sort of subsumed under the larger AAPI label without often enough data to do analysis the way we'd like, that our research might also be geared toward improving conditions for marginalized people rather than simply, we've identified a disparity, somebody should fix that. We can couple this thinking also with Kwan and the UG-COP to make interventions at every stage of research, from design to dissemination. And that's something in the biomedical informatics paper that we emphasized, was like, there are opportunities to incorporate intersectional thinking at every stage. So even if you already have data or you're working with secondary data, there's still opportunities. We can reframe access in more holistic ways by drawing from health and human rights, in that where care is available can be a really important piece, but only just one piece of the puzzle. And of course, that means we have to accept that adaptation of these approaches will be imperfect or piecemeal, and that doesn't mean we shouldn't try, but that we have to also actually try to know whether or not they work and what the pitfalls are for adapting them. Cool. So I went a little bit over. Apologies. My apologies. I apologize. I couldn't pick which one I was going to say.
No worries. Thank you, Dr. Everhood. So yeah, so thank you to both of you. And I'm not going to ask a question. I'll defer to the broader crowd, but I did appreciate how, just as one observation, I appreciated the similar kind of conceptual approaches toward using standardized empirical methods, but bringing light to understudied areas, particularly in places where there may be biases related to sexism, racism, queerphobia, ableism, or other issues. So I'll open the floor to folks. And if you're shy, feel free to throw up a hand first, and I can keep an eye on that too.
So both of your talks did a really nice job exploring like what access means, right? And the kind of the complexities of access. And like that is despite a lot of like geography research still focusing on, well, it seems like there's this bifurcation of approaches where even in geography, you'll have kind of the human geographer qualitative versus the quantitative. But I feel like both of your work does a really nice job trying to dissolve that barrier. But do you have any, I don't know, general comments on how other researchers can take that approach and how your work with folks outside of geography in your respective, departments helps or makes that more difficult?
I guess I can go. I didn't get to share that part of the presentation, but I do have a qualitative component to one of my projects where we're doing semi-structured interviews with rural dwelling cancer survivors experiencing financial toxicity. And it's been very fascinating because, so I'm embedded in a trial that's basically kind of testing out models of financial navigation to reduce the impact of financial toxicity among rural dwelling cancer patients. But the original trial didn't account for space or place, and that's what I brought to the project. So as being a geographer in academic public health, there's a lot of opportunities to collaborate with people in other disciplines, and even like not only in the school of public health, but also in the school of medicine. And it's just sort of a whole different infrastructure for research because it's the more applied side rather than the more theoretical side. And so definitely the mixed methods qualitative. It, I think that's the big missed opportunity. At least it was for me until now.
Yeah, I I feel similarly, I think, in that there's, yeah, I feel like there's a lot of, well, one, like we tend to, if we think about like reshaping policy, whether that be like delineation of health services, how much resources or funding is needed to accomplish certain things, like it's quant or nothing. Like they kind of don't, like decision makers want to be able to have a neat little soundbite. And that often means that even when we do really mixed methods work, that I think is kind of the answer, that we still have to be able to translate it in a particular way. And I feel like I have so little in terms of advice to offer that, because every time I've been like tapped to speak to a particular policy or legal issue, I show up and I realize I'm being like way too like I'm like, I want this thing. And in my mind, I'm like, of course it's feasible. And then people are like, I don't know that anybody's gonna go for that. So that's something that I'm wrestling with, is that at the end of it, like our role as researchers is really important because we're able to occupy a certain kind of position that, even though I don't think there's such a thing as being totally objective, that we're able to hold up our expertise and our research in a way that removes us from it a little bit, and that means it gets taken seriously. And I really value that. I think it's important, but I haven't been able to figure out how we also like bridge that with policy impact or a real world change. And I don't know why I feel that way, but maybe I'm feeling a little pessimistic lately. I'm not sure. I wish I had something to offer that was like practical, but
No, I appreciate both of your responses on this and gets to certainly the complexity of policymaking, even when we have some sense of what we should do or what we could try, even with maybe within a healthcare system or at a smaller regional level, experiment with, and that we often don't even get to the point of being able to test those, the long arc of translation science, as it were. Others with questions?
Just shout it out. The
Oh.
camera will find you. I think.
Thank you very much. I'm a PhD student at the University of Illinois. Maria is not my PI, but I always come to her labs events. So I have a question about, like the ontological differences across quantitative and qualitative research. So Avery, you talked about like there are some qualitative research projects that are not necessarily positivist. So like I want to know more about like how, like what non-positivist qualitative research looks like. And then, but also like, is quantitative research really positivist ever? That's my question. Because like I know like a lot of, I mean, I'm purely qualitative, but like I know quantitative scholars are aware of the risks of bias, and then like, you know, they don't necessarily believe in objectivity anymore. So like I'm just curious, like is quantitative research really positivist ever? And then my last question is, if quantitative research is positivist, then do the ontological differences really matter when quantitative research engages with critical scholarship? What kind of things do you think we need to do when we want to collaborate across quantitative and qualitative ontological differences? I hope my questions make sense.
I hope my answer makes sense. And I'll try to go quickly because I'd also love for Dr. Planey to weigh in if she has something to add. Yeah, if it's the case that quantitative scholars are no longer regarding their work as positivist, then I am delighted and thrilled, and a little surprised, but nonetheless delighted and thrilled. Even if we within research world are not doing that, there is still a way that in this moment of statistical illiteracy, in this moment of misinformation, in this moment of media illiteracy, as soon as we're able to deliver something in bite-sized numerical form, and I'm not going to soapbox, I'm writing a book, that'll be the soapbox, that it becomes fact immediately. And not only does it become fact, it goes from 0 to 60, 0 to Mach 5 in an unreal amount of time. And then it begins to circulate. So I think that at least culturally, societally, quantitative work is being regarded in a positivist lens, in the sense of this is a reflection of truth and this is exactly what it is. I do think that even if that's only coming from the outside, that necessarily means that there's ontological and epistemological differences in qual versus quant, mostly because of like how they're regarded. And they also have very different goals. Like qualitative work isn't necessarily about generalizability. It's about the type of rich narrative insights that we cannot always get. I think we should still strive for, but that we cannot always get with quantitative work or working at population scale. Whereas with quantitative work, at least in public health world, the goal is supposed to be on some level generalizability or at least reproducibility. So I think that those differences persist even if they're beginning to dissolve within the academy on our side as scholars and researchers. But my frustration lately is that they at least persist from the outside, and that shapes how our work is taken up.
I agree with your point. Oh, I'm sorry to interrupt. I think I agree with your point, Avery, because being in the Department of Health Policy and Management, it absolutely, quantitative results are absolutely taken as facts. No matter how much you couch it in terms of this applies to this population, it just becomes facts. And so it's just like, it's really challenging for me because I like to approach my work with a certain humility, but then when I'm asked to talk to the media, I'm expected to provide like the answer. But for me, I still see knowledge, all knowledge is contingent. And I'm just like chipping away at one part of it.
Yeah, for sure. I appreciate that particular point, chipping away at this, and going back to both of your work on access and the fact that we have been studying these questions now for, I mean, at least with modern GIS, I think for at least 35 years. But GIS is still relatively new in the broad arc of research history. And oh, forgive me, I forgot to remove the spotlight and add the spotlight to Dr. Planey. Sorry about that. But yeah, that we're slowly advancing, but we are advancing, I think. I've been encouraged in my short career so far, or medium career, I guess, as it were, the progress that scholars have been making. Is there one more question? I know we're over time, and certainly, of course, folks have been dropping off, but Drs. Planey and Everhart did confirm they could take one more question if there is one. And of course, I imagine they would be happy to field emails if there are additional thoughts, and also to catch up with folks at future conferences if you see them. All right, I will leave it at that then.
Go vote
Oh.
tomorrow.
What's that?
Vote. Don't forget to vote tomorrow. Okay, everybody.
If you haven't already, yeah,
Yeah.
totally. Any parting thoughts, Ariana, Avery?
Thank you. It's so rare that I get to be with medical geographers now.
Yeah, honestly, same. It's a nice perk of being with the specialty group here. And we'll look forward to seeing many of you in Detroit in just a few months.
Looking forward to it. Thanks for having me.
Of course. All right, thanks everybody. Be well. Take care of yourselves.